right. Here we go. I think we got it set, finally. Some technical issues. We're here today to talk about racial equity and improving access to care. We are CA Bridge, and we are part of Bridge organization, but as well as Public Health Institute, and we share all of our materials, including this webinar will be recorded, and you can see it at another time. So for today's best experience, the one suggestion out of all of these, if you have a question, please address it to everyone in the chat. When you hit the chat button, you will see a blue button and it'll say panel, host, everyone. Please pick everyone so that everybody will know what the question was, okay? CA Bridge, we don't change. Our goal is to have 24/7 access to high quality treatment of substance use disorders in all California hospitals. And we've superseded our goal. We're at about, we're not quite an A, but almost 90%. So we're really proud of our goal and what we've progressed to. So CA Bridge model, what is it? You guys can tell me this. It's a three-pronged approach. We are revolutionizing the system of care for substance use disorder. We start off with low barrier treatment, making it easy for patients to access care. That's what your doctors are doing by giving buprenorphine, by giving naltrexone, all in the hospital emergency. The second pillar is connection to care and community and culture of harm reduction. That's all my navigators and our CHWs and our peer support specialists and our substance use counselors. That's what you're doing every day. You're connecting these underserved population to resources to help. And so that's what you do by navigating. And then of course, we have over 200 hospitals in California that are giving out free naloxone for harm reduction. And that is huge. So I just want to say thank you for improving care for patients that really, you know, they had no hope until our navigators and counselors and everybody came to the hospitals. We have a few announcements. We have our Navigator update. That is our kind of our time to ask questions, and Latoya's in charge of that. And you guys are wonderful at attending. And that's a 30-minute question and answer session. And next February 12th will be professional growth. Next month, our Navigator Focus series will be talking about ethics and advocacy basics. And that's always an important topic, especially if you need a CEU renewal provider. We will give out those CEUs. We're really happy to announce our new program, Regional Navigator Mentor. You have a chance to become a volunteer with CA Bridge. We are starting a new program, launching it. They are the regional collaboratives, and these will be held in different regions across California. If you are interested in volunteering for these collaboratives, please let us know. Right now, we are accepting applications for Northern Bay Area, Southern Bay Area, Long Beach/OC. So if you are interested, please let us know, and we're going to put that in the chat right now. These are our objectives today. And we can read those. I'll give you a second. And without further delay here, I am so happy. Like I said, I'm going to cut it short because you guys want to hear from her, not me. Dr. Nola Veazie is back with us. And if you were here last year, she gave a wonderful training on implicit bias. And it covers everything from racial equity to improving access to care. And she never has enough time because we love the engagement and discussion that she brings to CA Bridge. But we wanted to bring her back for part 2. And it's okay if you didn't have part 1 because you'll fit right in. Don't you think, Dr. Nolan?
Absolutely, absolutely.
So I'm going to get handed to her, but she is a CEO of a consultant for training and staff development, and she is also a psychologist. So I'm going to hand it over to you, Dr. Nola Veazie.
Thank you so much. I want to give a shout out to all the navigators. I wish I could see you because I like to interact. Sherry, thank you so much for just inviting me again. Today, we're going to be going through some stuff. I'm going to repeat some of the things that I covered last year, especially definitions, but we're going to get right into it. And so I'm going to share my screen. Hopefully, I have no trouble sharing this. No technical difficulties, because as soon as you think everything is working, it stopped working. Well, good morning, everyone. Today we're talking about racial equity and improving access to care. But guess what? We cannot talk about racial equity unless we cover a four-letter word. You know what that four-letter word is? BIAS, bias. And we're going to be talking about bias and what that entails. But most of all, what do we do? How do we look at our own bias so that we can provide care to our clients, to our patients in a way that brings empathy, in a way that makes them feel worthwhile? So let's first talk about what bias is. So bias is a disproportionate inclination in favor or against an idea, a thing, or an individual. So we all have biases. We have favor. We have disproportionate inclination towards certain things like foods. Babies, they're born with bias. Some babies, they make up their faces if you give them that spinach or something they don't like, so that they have an inclination towards something. The problem, though, with bias is that disproportionate inclination is usually in a way that is closed-minded, prejudicial, or unfair. Bias can be learned or bias can be innate. And when we talk about innate bias, we can look at children and how they prefer certain foods over other foods, and that is an innate bias. But bias, and I'm going to define and I'm going to bring up implicit bias. When we think about bias, though, we cannot define it without first talking about something called implicit social cognition. You see, our bias is predicted or predicated on implicit social cognition, how we view our social environment, how we view people around us. And what implicit social cognition says is that we're more likely to predict behavior when the individual lacks a certain thing. For example, we are more likely to not change courses or not change our biased views if we're not motivated to deliberately direct that bias or direct that behavior. So, in other words, when we look at ourselves and we think in terms of social cognition, if we're more likely not to be motivated to directly deliberately or directly change courses because of our biases that we want to hold tight. The other thing is that we're more likely to predict a certain behavior in individuals that lack opportunity to initiate relevant behavior. So, for example, if we learn about implicit bias or we learn about cultural competence, but we do not change based on the relevant behavior that we have that is not aligned with for example, with cultural competence, then we're more likely to stay stuck. The other thing about social cognition is that the behaviors are more likely or more predictable when we have an ability to control a behavior, but we choose not to control that behavior. For example, we have lack of emotional regulation. And so if we're not able to control or regulate our own behaviors, our own emotions, then we're going to act in a way that is based on our biases. And then lastly, social cognition says there's a lack of awareness of the factors that influences our behaviors. For example, there's a lack of awareness of culture. There's a lack of awareness of environmental factors that not just predict, but that kind of it takes and paints with a wide brush how we see our environment, how we perceive others, and how we perceive our interactions to others. But we cannot talk about bias without really understanding that bias is either implicit or explicit. Explicit bias, we know that we have a bias and it comes out in our conversation. Now, implicit bias is more, and I'll bring up some of the things. Implicit bias speaks to those biases that are outside of our awareness. We're not aware that how I come off, how I interact with you is based on bias. So the definition of implicit bias is prejudice that is based on our attitudes or our associations that are held internally. So these are internalized uh, beliefs, internalized views of the world, internalized ways of how we look at the world, and they're unconscious. And as I said earlier, they can be innate or they can be learned. But there are three questions that we have to ask ourselves when it comes to implicit bias. Because if bias is based on my attitudes or how I associate the individuals that I'm interacting with, the environment that I'm interacting with how I think about them, then it's going to affect how I interact with my clients. So the first thing is, how does bias affect your understanding of your clients? How does bias affect how you view your clients or how healthcare providers view their patients? The second question is, how does bias affect healthcare providers? And we're going to talk about all those. And lastly, how does bias affect the decisions that I make? How, when I make a decision about dealing or interacting with a client, how does my bias affect the decisions that I make about the client? How does my bias affect how I interact with that client? Well, let's look at, as I said, implicit social cognition. And I kind of went over that. It predicts those behaviors that it says that an individual lack motivation to deliberately or directly take their behavior in a way that is not covered or is not brushed by bias. It also talks about the opportunity to initiate some irrelevant behavior that are different or are not clouded by the way I look at clients, the way I look at the environment, and also the ability to control my behavior. We're going to skip that because I went over that. But how does your view affect your interaction with your client? And I think that's the most important thing. How does how I think affect how I react, how I interact? So, number one is it makes judgments and assumptions about the person that, for example, someone who is dealing with substance use disorder. One of the things that it does is it creates unfounded assumptions about the client's behaviors. For example, we look at people with substance use disorder, and I'm going to be talking not just race and ethnicity and values. I'm going to talk also about people with mental health and people with substance use disorder. We make judgments and we make assumptions about those clients that creates barriers between us and the person that we're supposed to help. So, unfounded assumptions about the client's behavior can create those barriers because we look at a person and say, yeah, they normally behave that way, whether it's because of substance use, because of race, because of ethnicity, because of culture, or even religious beliefs. We group people and we say, we have assumptions about them because of the way they look, because of the way they act. So number two, when we make judgments and we make assumptions about a person, we also reduce our ability to empathize. If I see someone who is, for example, I'm going to use substance use disorder. If I see someone with substance use disorder, I make certain assumptions about that person. And when they come into the healthcare system, it reduces my empathy and I see the person as another number. Treatment options are changed because we're unable then to advocate for that client because we believe the client, either if they have substance use disorder, they're in denial about it, they're resistant, or if we see someone who is different from us, we have assumptions based on biases and based on implicit social cognitions about that person, about that group. Additionally, it provides inequity in the treatment. We cannot communicate effectively with someone who we feel is different, and because of those differences, we have negative assumptions about them. We may treat them as less than, or we think that that particular group may not deserve certain benefits, for example, in healthcare. Now, look at some of the statistics that show that when doctors had or held these implicit bias, how they treated their patients, and for us, our clients, was very different based on those assumptions. So, what is the effect on healthcare providers? It's a little different than the healthcare, our understanding of clients. First of all, it impacts their decision making. When a healthcare provider makes unconscious attributes or decisions or attributions about about a person and their symptoms, there's stereotypes that are generated rather than exploring all the possibilities. Again, going back to someone with addiction, the assumption is that the person is coming into the ER, for example, because they're drug seeking. The assumption is that, for example, people of color specifically, and that is based on several of the studies that have been done, have a higher tolerance for pain, and therefore do not need medication, when in fact the person's pain could be higher than the doctor is predicting. For example, when we assume that chest pain in a young woman, because a lot of these assumptions, a lot of these implicit bias affects not just race or ethnicity, it affects gender. They may feel like a woman, especially a young woman, is her chest pain is anxiety related rather than a potential cardiac issue. So if a young woman comes in, especially a young woman of color with chest pain, a person, a doctor who is holding implicit bias may wrongly predict that the person has anxiety and send them home versus doing a workup, a thorough workup to find out, hey, maybe there is something going on that is more impactful than just anxiety. Not that anxiety is not impactful. So, studies show that implicit bias can result in discrepancies in the way we treat, the way we offer treatment, such as pain management or advanced medical interventions. So, it impacts clinical decisions. The second thing is that it impacts the patient provider communication. Implicit bias can lead to less patient centered communication, such as interrupting the patient more frequently or using dismissive tones with certain groups. It also impacts the trust and the rapport that should be created between the doctor patient or between even you as a navigator with your clients. Patients who sense bias may feel less valued. If I come to you and I'm having chest pains, for example, and I'm dismissed, or I'm told that maybe no, you're just having anxiety, it really breaches that connection and the rapport that should be provided, that should be created between me and my provider. So I said that it gives the patient a sense of not being valued, which can erode the trust, and the person may not want to come back. They may not want to see the provider, or may think, you know what, they're not going to believe me anyway, whether it's a medical issue or a substance use disorder or a mental health issue. The other thing that it does, and let me step back, is the disparity in outcomes. When there's inequitable care, inequity in treatment, implicit bias can contribute to health disparities, particularly for marginalized groups, including racial and ethnic minorities, LGBTQ, or individuals with disabilities. So patients who experience biased care may be less likely to adhere to any prescription, prescribed treatment, or prescribed medication. I'm going to go back a little bit to patients with substance use disorder. If we treat a patient in a way that is inequitable because of assumptions that we have, and we're expecting the patient to adhere to whatever the treatment or the medication or the intervention, they may, and we haven't built that trust. We haven't created that rapport with the patient. What would happen is that the patient may not adhere to the prescriptions that you're providing. Also, the perception, I talk about that a little bit, the perception of pain and suffering. Research shows that some providers are less likely to believe the pain levels reported by Black patients, women, or those from lower socioeconomic backgrounds, which leads to undertreatment. So your pain, if it's not addressed, if it's not viewed as legit or of value because of the group that you come from, the group that you belong to, then you're not going to get the treatment to deal with the level of pain that you might be dealing with. Here's some other, let me bring that up. Before I go to the statistic, there's some other things that really prevent quality care when providers in the healthcare business or even navigators or mental health providers have implicit bias, barriers to preventing care. Providers may unconsciously deprioritize preventive care for certain populations, reducing the opportunities to address health issues before they become severe. Before a person who is in a minority group or a socioeconomically disadvantaged group is able to seek health care when they see things on the news or they see how providers have dealt with them, it unconsciously they deprioritize those people and say, well, maybe you may not need this level of care, or put the person in a lower level of care when they may need something higher. And the last thing is stress and burnout for providers. When providers have implicit bias and it goes unexamined, they can increase their cognitive load and stress, contributing to burnout over time. So, what are the statistics? Let's look at some statistics here. Between 2005 and 2016, medical professionals were 10% less likely to admit a Black patient in the hospital than a white patient or a patient who was from an Asian background. In 2014, around 20% of Black adults, 35% of Latinx adults could not access healthcare compared to 10% of white or Asian adults. And then people with histories of addiction were often perceived in a negative light. For example, they were seen as people who were drug seeking and that their behavior, rather than painful or something else that might have been going on, was just looking to find drugs. Now, it is true that some people with addiction are looking for drug and it might be drug seeking behavior, but we cannot filter that through the lens of bias. So here's the effects of bias on navigators. This is you. I'm not a navigator, but you play such a significant role. And you're the gatekeeper for clients coming into the hospital and for you to communicate and to translate what is happening with the client. But if you have bias, it hinders your ability to provide equitable support because, number one, it impacts your judgments and assumption. For example, clients again with addiction, implicit bias may lead you to view clients as morally weak, a person with addiction as unreliable or undeserving of help, rather than recognizing that the addiction is a complex condition that is influenced by biology, psychology, and social factors. You may view clients who are different because of implicit bias. It can cause you to make unfounded assumptions about their behavior, about their capabilities, and their values. And those are based on stereotypes that are held because of implicit bias. The other thing that the other way that bias can affect you as a navigator, it reduces your ability to be empathic. Implicit bias can reduce our ability to empathize with individuals whose experiences or their identities we don't understand or they're different from ours, especially if the individual is facing challenges. We are then unconsciously stigmatize them because of those held implicit biases. We want to be empathic, and as navigators, as providers, as people who help, people in the helping field, we have to have empathy. That's the number one, and bias reduces empathy. Bias also causes, especially implicit bias, causes inequality or inequitable communication, the way we communicate. And it's not always our verbal communication. But if I think a certain way of someone, it shows up in my tone, how I speak to the person. I may be more condescending. I may be more dismissive if I have or I hold implicit bias about that individual. It shows up in my body language. We're more closed off, or we fold our arms, or we separate ourselves from the person. It also shows up in the amount of time that we dedicate to understanding the client's perspective. Bias, what it does is it clouds how we view others with our perspective. This is the way things should be, the way I think. And because I think of the environment a certain way, or because I hold certain values, then I project those on others, like our clients, whether I'm a healthcare provider or I'm a navigator. I may then tend to agree with someone in healthcare, the healthcare provider, the doctor, the nurse, based on my biases if it aligns with their biases. That's again social cognition or implicit social cognition. So we want to look at our communication and see, is it equitable or is it inequitable, the way I communicate with someone because they're different than I am? Unconscious overgeneralization. That's another way it affects not just you as a navigator, but it affects people in healthcare, throughout healthcare, the doctors, the nurses. Implicit bias might lead to overgeneralizing past experience they have had or you have had with a person from a certain group that is similar to the client you're helping. Rather than seeing the individual in front of us as unique, they have their own set of values just because they belong to a certain group, whether it's racial group, um, whether it's ethnic group, or socioeconomic group, or a group that is plagued by substance use disorder or homelessness. It doesn't mean that that person is like every other person within that group. So unconscious bias, implicit bias leads to overgeneralizing. And then it has an impact on our decision making. How I make decisions, especially when colored by implicit bias, may not be in the best interest of the person I'm trying to help. So, what I would say is to step back and see, what is my thinking and how does it color? How does it paint how I see the client or the person that I'm helping? So, how does bias affect care? What is bias when it comes to treatment? Number one, it affects care because it provides poor quality of care to underrepresented groups, and it's based on the following. It's based on race, and we talked about how some studies show that some, and not all, but some providers view Blacks as having a higher threshold for a higher, what you call it, for pain, and because of that, may under uh, medicate. Gender. We talked about gender, and for women in particular, going into to see your doctor, you may be seen as someone who is having an anxiety attack or maybe just more hysterical rather than having something that is heart related. Social class, and we know that people in lower socio or depressed socioeconomic classes are not always cared for the way people in a higher class is treated, and may be dismissed, may and the provider may not be consciously thinking this way, but because of unconscious bias, their relationship, their interaction with people of certain classes may be different, and it may not come off verbally, but certainly in the nonverbal ways, in the ways we interact with the person. And then ultimately, given diagnosis that may not be warranted. There were studies that showed that diagnosis of schizophrenia and some of the more severe mental health diagnoses were given more often to people of color, when in fact that was not the diagnosis. It was given to people from different ethnic groups and different cultural beliefs. Rather than finding out, hey, you thinking that you are seeing your grandmother who recently died may be just more compatible or in line with your culture and the cultural beliefs. So understanding different cultures is very important in order to expel some of the thinking that we have kind of brought up by our implicit bias. So, what should we focus on? We need to focus on the impact of cultural competence in treatment. The more we know about different cultures and how the behaviors may differ than my own behavior, the better providers we are, the better navigators you are, because then you can advocate for that client. You can talk to the provider and talk to the client as well, educating the client about these biases. And it may not be personal, what the doctor is doing or what the nurse is doing, or even what I'm doing. It has more to do with the biases that they may not be aware of. We need to focus on the diverse experiences of clients, the diverse experiences that we all have. None of us have the same experiences, even when we're coming from the same group, whether it's a racial group or a gender group or any group that we belong to, our experiences are different. And that's why we have to provide individualized care. The values. When we talk about experiences, we need to look at the person's values. I need to get to know the people I'm working with. Who is my client? What are their values? What are their beliefs? Like I said before, some groups, some cultures believe that, hey, I do see my loved ones when they transition. I do interact with my loved ones when they transition. That does not mean that the person is delusional. You have to understand what their values are and what their beliefs are to understand that person. And then the cultural context when we're talking about substance use disorder. Uh, Sometimes we can diagnose people with addiction or substance use disorder and say that that person is really resistant to treatment because they feel that it's okay to celebrate drinking a beer with family because the culture kind of celebrates that. Of course, we want to talk to the person. We want to find out biopsychosocially, is this affecting you? And help the client, help that person using techniques like motivational interviewing so that they can see that the values they hold, how it may or may not be hurting them, especially as it comes to substance use. And then we want to look at underlying trauma. A person's behavior may be predicated, may be elicited or brought up because of some underlying trauma. For example, Your client may go in to see a doctor, a male doctor, and throws a fit or doesn't want to see the doctor, doesn't want to go back. It doesn't mean that they don't want care. Perhaps that person had some type of sexual trauma and it was done by somebody that looks like that male doctor. So we want to consider underlying trauma when we look at people's behavior and put it in the right context. Cultural competence. How do we become culturally competent? We have to start by acknowledging that we all have biases. None of us, I didn't like spinach until later on. I said, let me try the raw spinach in a salad. And I said, this is not bad. It kind of tastes like grass, but hey, it's good, it's healthy. But we have those unconscious bias about things that we look at and say, that doesn't look good, so I don't like that. Or we look at individuals and decide based on our experience with an individual who looked like that person, that entire group is not worth my interactions with. That entire group is not worth me valuing them as people and thereby providing good care, good medical care, good psychological care, just good care. And for you as a navigator, you want to look at people and say, you know what, that person is valuable, even if they act differently than I do. And trying to understand, where is it that behavior is coming? Why the behavior? And we can use all kinds of techniques like motivational interview and open-ended question to get the background, to get the backstory, so to speak, about the person and their behavior. We want to integrate culturally competent behaviors and attitudes in our treatment. And competent behavior just means that I am going to be non-judgmental. I don't understand the behavior. I don't agree even with the behavior or your thoughts or your values. But me not agreeing with them does not mean that I'm going to be disagreeable with you. We can disagree, agree to disagree, but we do not have to become disagreeable, especially if we take our time to learn about somebody else. So integrate culturally competent behaviors and attitudes in any treatment that you provide or even the interaction as navigators. And the more you understand the culture, the values, the beliefs of another person, the more you're able to advocate on their behalf. Also, let's step back and say, you know what, the doctor, the nurse, the provider may not be in consciously at least trying to hurt the individual. You are in such a good position, navigators, to educate doctors, to educate healthcare providers, to say, hey, I noticed that when you talk to certain patients, I see these maybe nonverbal actions that may make the person feel a little undervalued or not valued at all. And so you can advocate, you can educate. We want to match clients to providers and programs that are based on language preference. Certainly, we don't want to have an individual who may not speak English at all match with somebody who is, number one, doesn't speak the language, doesn't provide somebody to translate, and is impatient with the individual because there's a language barrier. It only adds to the feelings of undervalue for people who, because of language, are different. You want to match the person when possible. This is not always possible, nor is it convenient to match a person with the same cultural background. Obviously, we go to the doctor, and whatever doctor is there that we can see, we're glad to see that doctor. But we want a doctor, we want a nurse, we want a practitioner who is culturally competent and can help. Treatment access to minority communities, doing due diligence, back checks to see, hey, maybe this hospital or that clinic provides treatment specifically for this group, and this person may feel more comfortable there. So looking for those treatment access and treatment treatment, those treatment, I'm trying to think of a word, but it's just looking to see if that is available is the bottom line to the individual. Also making sure that the materials are translated in the language for the person if they don't understand or they don't read a language, to ensure materials are properly translated. So what can you do? You can model non-judgments, a non-judgmental attitude. What does that look like? And we talked about that earlier. A non-judgmental attitude is looking at the clients in terms of, this is a person suffering from addiction, for example. This is a person who holds values or who holds beliefs that are different from me. This is a person who's different from me, but may have the same values. And we don't know that unless we get to know the person. So we want to model that non-judgmental attitude. We want to build trust and rapport. The only way to build trust, the only way to build rapport is to talk to the individual and to listen to the individual. Many individuals, for example, with addiction may face judgment or discrimination from healthcare providers or society at large. Peer navigators can help build that trust by creating a more comfortable space for the patient, the client to share their concerns. Not just people with substance use disorder, but people who come from different backgrounds, whether it's racial backgrounds, ethnic backgrounds, people from the LGBTQ community, people who believe differently than you. It's creating a place where the person can interact. Again, I'm not saying that you have to believe what they believe. So although we disagree, we don't have to be disagreeable. So creating that space will build rapport with the individual. Educate healthcare providers. I talked about that a little bit, but you can also work with healthcare teams to address their own potential biases by sharing their own stories, their insight into lived experiences, and how it has affected them. Maybe the healthcare provider had a really bad experience with someone who belonged to the group who the client belongs to, the patient belongs to. And so they have their own trauma. But the more educated we become, whether we're healthcare providers or navigators, the better we are at dealing or interacting with others, not colored by our own experience, not colored by our own trauma. Advocate for the client, advocate for the patient. If a peer navigator perceives any bias from a healthcare provider or the system, you can act as an advocate, a patient advocate. This could involve speaking up on their behalf or ensuring that they get the best care possible. Promote cultural competence. And how do we promote cultural competence? Again, that is education, education, education. By demystifying some of the thinking that we have, by being more conscious of our own nonverbal attitudes, nonverbal behaviors, that we might not be aware of. Being aware that we are all subject to implicit bias. Practical solutions. Create a safe space for discussion. Provide emotional support. None of this is rocket science. This is stuff that we all know, but we sometimes forget to do, or we forget that it's important. Just providing support. Encourage self-advocacy. This is a sticking point with me because we can advocate all day long for our clients. But if we don't teach them to advocate for themselves, when they are not in your presence, when they're talking to somebody else or another provider, they have to be able to advocate for themselves. So teaching people to stand up for themselves. And they can't stand up for themselves or advocate unless the person feels worthy. I remember one time I was doing a training, and an individual, a gentleman, just broke my heart, said, you know what? I can do that with my clients, but for some reason I go to the doctor and I don't feel worthy to stand up and say, no, I don't want that medication. or I don't think I'm getting the right treatment. We have to be able to stand up for ourselves, to advocate for ourselves and say, well, maybe you're giving me the wrong medication, or it might be too much. This is how it's making me feel. I've taken it before. Rather than feeling like I have to do what you say because you're the healthcare provider. Cultural competence goes beyond just dealing with race, beyond doing all the things that we talked about, but it goes so deep into the understanding of another individual through empathy and respect. Offering tailored guidance. Here's some things that you can do. I've had that experience myself, and here's some things that work for me. It may not work for you, but here's some advice. So, tailoring the guidance to fit the individual's need, addressing systemic bias, because, and I just go back to that a second time, systemic bias does exist even in 2025. And so we must be aware of that. And because we become aware of it, then we must act. And it's not about marching or shouting or doing any of that, but simply advocating and having the person advocate as well for themselves. So here's some suggestions for professionals. Be introspective. Know yourself and your own bias. Be aware that, you know what, we all have bias. Apply cultural humility. We don't know everything about somebody else's culture. I've traveled extensively and I've been and lived in other countries, and I cannot begin to say that I know about them more than they know about themselves. I barely know about me, and I'm learning a lot about my own cultural background, how that affects us as a people, how it affects me individually. So, cultural humility says that, you know what, I don't know more about you than you know about yourself. Don't work in isolation in a silo. Uh, your supervisor, hopefully you have clinical supervisors or someone within your team to say, hey, I'm experiencing this and I feel this way. Help me out here. Be aware of the role of power, especially in a therapeutic type relationship. Uh, Doctors and nurses and navigators, professionals are seen as the powers. When a person is sick and they're coming to you and they're looking for care and they're looking for help, there's a power differential. And so they may take everything you say, and if you're saying things out of your own implicit bias, it affects the individual. So be aware of the role that power plays. Be aware of your own power and your own thinking. Understand even how media informs implicit bias, because we're human beings and the people on TV are human beings and they bring implicit bias to the table as well. I want to leave you with this. Before I end, I want us all to make a commitment too. I'm going to make a commitment as a peer navigator. I'm not a peer navigator, but as a psychologist, as the CEO of V Solutions Consulting, I want to make a commitment to eradicate bad treatment because of implicit bias. I may not always be aware of my own implicit biases. I may not always be aware of how I come off to another individual because of those implicit biases. So I want each and every one of you, I can't see you, you can see me. I want you to, of course, you're muted, to verbally say, I, as a peer navigator, or whatever role you play, or if you want to put your name in there, I will commit to. And then write what you're committed to do in order to diminish, to reduce how implicit bias affects others in healthcare, affect our clients, affect people, because our clients are people. I know we give them that nomenclature, client, patient, but sometimes we forget that a patient is a person. A patient belongs to a certain group and is a member of that group. Sometimes we forget that a client may suffer from addiction or suffer from diabetes or suffer from a lot of different things, but it does not indicate who that person is. It does not define the person. So if I were to say one thing and leave you with one thing, beside us making this commitment, is that implicit bias has a tendency to define people based on what we see and based on what we think about them. And sometimes we're wrong. Sometimes we're wrong. We start to define people erroneously based on our thinking. So I'm going to leave you with this. And I'm going to wrap up because I don't know if I have an opportunity to kind of field some questions. I want to hear from you. What do you think about your own implicit bias? Because we have all have bias. And what are you willing to commit to today? So as I wrap this up, I would like to hear from you in the chat if that's okay. I don't know if we can have an interaction. That's why I like training in person versus webinar, because I like to see people. I like to see your face. I want to see, because I'm visual, what you're thinking through your nonverbal. So I'm going to wrap it up with this. Again, what commitment will you make today? Thank you guys again for having me. Let me just stop my sharing. Latoya, I see that you're on. Thank you so much. I want to hear from people. I want to know, before I go, hey, what questions do you have regarding this?
Yeah, that's actually really awesome. And what I was going to also ask of the attendees here today, what questions do we have for Dr. Nola? We all for sure agree that this is a really great training. And I honestly learn something new every single time I hear you speak, which is now averaging at least twice a year. But it's such great content, so many great words of wisdom. And so I really hope that people have some questions here. Oh, there was a question for what other training. So Dr. Nola Veazie does a lot of trainings, including at the CADTP spring conference. I've seen you 2 years in a row there.
Speak at different conferences. Katie, I've spoken at Katie, CADAP, and CCAP conferences, but we do a lot of training and consulting for organizations. And so organizations like Amity Foundation, Phoenix House, Behavioral System, they have contracted with us and we provide trainings because we are CEU providers. So we provide CEUs.
Yes. Great. Well, while you guys are thinking of your questions, I'm going to just kind of close out with our final slides here for a moment. Please drop your questions in the chat. We want to hear them. We want to see them. We want to know what those questions are, so that we can get them answered. We have, creme de la creme speaker here, to be able to answer those questions for you. All right, let me get my screen up.
Right. I just kind of want to do an announcement. I just published my next book that I think kind of helps with that a little bit. It's called the Motivational Leader. And it's just a book for leader if you want to become a better leader and stuff and help to develop the people, the personnel that work for you, your staff. I think this is a good one because it addresses those things like implicit biases as well.
That's really awesome. So we have somebody in the chat asking for your contact information.
Put it in a chat.
Yeah, so there's a couple of them asking for asking to be able to reach out to you.
Yeah, I'm gonna put my email in the chat right now.
Okay. All right. So this is typically just a really brief knowledge check to see where everyone is with, the great content that you were able to learn and listen to today from Dr. Nola Veazie. You will get these slides in the follow-up email, so feel free to go through this knowledge check. As a reminder, here are our resources. This QR code takes you directly to our website where you can access all of our resources completely free. And there's over 100 resources, tons of them on there and available for many different disciplines. Really great stuff. We also have our CA Bridge Academy. Again, nice nifty little QR code here with our CA Bridge Academy. As a reminder, we provide CEU training modules available for clinicians, for nurses, and especially for our navigators / SUD counselors / CHW / all of it. Okay. Here's our contact information. You can always reach out to us with any questions you have for the Bridge team, mentors@cabridge.org. Your lovely Navigator team, including myself, Tommy, and Chaya, and Sherry, of course. So that's all I got for you. Thank you very much. We have 2 minutes left, so I'm going to go back and look and see if we have any other questions.
Oh, there's a person, Rudy asks, how can my organization in Cambridge, Massachusetts partner with you? As a matter of fact, our company is a provider in Massachusetts. We are certified in Massachusetts. So you can reach out to us at any time and partner. I put my email in the chat. I also put my website in the chat.
Dr. Nola, oh, we got it. Never mind. I was going to say it was addressed to the panelists, so everyone else in the chat didn't see it, but we got it in there for you. Okay. All right. Well, we give you all 1 minute back to your day. Thank you again for joining us and being a part of this really great, fantastic training. And I hope you all have a great rest of your day.
Thank you, Latoya. Say hi to Tommy. You guys are so great. Hopefully, I can work with you guys in different capacities in the future. Take care, everyone.
Oh, I love that. Yes. Okay.
And just call me. Bye-bye.